tell us about what has been done other than what you did, and then tell us about what you did.
Yep. So the real idea, the real issue with surgical simulation is that, like I had mentioned, the people that are utilizing simulation the most are the ones that are already either doing a type of surgery and need to adapt to a modification, or are trainees like yourself that have been more exposed to patient care from the very early on, right? Robotic surgery was basically a faculty-based thing. Now then it was a fellowship based thing. Now it's a lot of residents graduate competent in something now, as difficult as robotic surgery. And you can look at any other types of urology or urology technology, urology procedures where it's the same thing. And so the people that are actually utilizing simulation have tried the best thing there is out there, which is patient care. And so if your simulation platform does not really give them the same feeling that they have when they are operating on a real patient, then that is an issue. And a lot of people think that the gold standard is cadavers. Cadavers are actually some of the most difficult platforms to perform simulation on. I've done a significant amount of them. The tissue consistency is different. It is just the best anatomical platform, and that's it. But really, how many cadavers have I gone in and found their prostate removed and then
Right.
had to do a semi-prostatectomy?
Right.
How many of us have presented to just take an upper pole of a kidney off and say we're doing a partial nephrectomy, but that's not a tumor, we're
Right.
pretending it's a tumor. And so those are very difficult platforms. So what I strive to create is to create something that looks, feels, and acts like true surgery, right? And so to attain that, we needed to develop, number one, a platform or a technique that allowed us to do that. But number two, do a significant amount of testing and prototyping and retesting in order to make sure that our tissue consistency is truly replicating what real life surgery is like. And so I was also from the very beginning defined. So my journey started teaming up with a biomedical engineer and then sitting down and doing some of their own engineering research myself. And then sitting down and trying to understand what is out there and what we can do to replicate and develop a training platform. 3D printing at that point was really a huge thing. And it was very clear early on that the solution is not to directly print the organ. That's what everybody does, and that's why they're doing it wrong. What we do is we print molds and then pour a hydrogel inside that molds that allows us to register different structures inside. And I
Love
remember the first time we got a small Petri dish and we had a small vessel that was running in it and we made it bleed. And I was suturing it to see if it closes. And I remember that we tried it and actually I controlled some of the bleeding, but it was still bleeding. And I continued to try and try again, almost spending 20 minutes until it was completely sealed. Because as a surgeon, your
Right.
intuitive nature tells you that you have to stop the bleeding, right? And so at that point, after spending 20 minutes in a Petri dish, I knew that I was onto something, right? We were hooked onto something that was truly, valuable and had the promise or the base that allowed us to build on it. Add to that we were able to get a software that we can segment patient CT scans to develop CAD models that when we develop molds out of what really makes us different from anybody out there. The technology that we use is very simple. It's a combination of multiple types of technologies, but what really makes our work really different from anybody else's work is our insistence that we want to perfect what we're doing. And so we go through almost 12 to 15 prototypes for every single model in order to really continue to improve it to reach the perfection standard. And we're pretty close on prototype number 5, but those fine refinements, it's what make a big difference between a true simulation that truly makes you feel like you're doing real surgery versus one that you have to pretend that you're doing re-surgery with. So that's what really differentiating factor. And that's why we're still a research lab and will always be a research lab, because you can't do that in a commercial world,
Right.
right? You want to get to the prototyping phase as soon as possible. We continue to develop and redevelop until we really hit perfection.
It's so impressive. I gotta say that, for me, I was been watching for you could see the prototypes develop, and you could see, even just from afar, some of the things that you had to overcome as you made these models and the things you were thinking about and how different it looks now. And it's really, really cool. Really impressive.
Thank you for that.
With that in mind, what's it being used for?
Yep. So we wanted to create these model in a way that it really allows for an educational experience. So, again, I early on decided that I don't want to be focused just on model building. That's great. It's a great passion, but my true passion is education. So I went forth and got a full master's in education to really understand. And you can imagine, as surgeons, we're not good with theory, right?
Right.
And so to really get to understand the theories of learning and how we teach different people, and this is a master's that was focused on health profession, but still went into high school and college and different aspects of learners, and trying to craft then take that theory, which is very regimented, very long, and then squeeze that into something in which we can apply in the fast-paced surgical world. That's what we've been trying to do. So the model to us is a medium. We want to instill it into curricula. And so we've looked at three different buckets, right? We want to look at, long-term learning, which basically we're doing here at the Brady Urological Institute, where we've developed curricula for different levels of residents. And they go through the entire year mastering a certain aspect or a certain procedure, whether it's endourology or reconstruction or robotics or open surgery and peds. And so we have them, in addition to going to the operating room and learning there, they're augmenting their training utilizing our simulation models led by an expert proctor. Because if they just go in there and cut through tissue, no, that's not valuable. You need
Right.
some level of guidance from a faculty. It doesn't have to be every time, but it has to be on a very regular basis. So that's what we consider consistent learning. We have video-based lectures that they watch. We have ways in which we grade them as we're moving forward. So it's a very time-intensive, resource-intensive way of learning, but the outcome is very rich.
Yeah. What
We
have
have
you found?
another
Oh,
aspect.
yeah. Sorry.
Yep. That we look at masterclasses, right? So this is mainly focused on new technologies. Like we have a course coming up in October that's a, prostate enucleation laser course. So these are practicing surgeons or fellows that are interested in taking that up or want to refine their skill. We have 10 experts flying in, and we're doing it in our training center. And basically what we do is in 2.5 days, we have them go through a mastery process. We evaluate them beforehand and then have them get proctored with faculty, a lot of hands-on, a lot of discussion lectures, a lot of semi-live surgeries. We actually have a live surgery from the OR, and then you do a final evaluation. So we know what their skill level is coming in, and we know what their skill level is coming out. And we actually sign off on them being able to go back to their institution and do these cases. So that's what we call master classes, which are very short. They're short for a reason, because these practicing surgeons are quite busy. And so you want them to come in, build on the knowledge that they have, and then reach professional competency very quickly. And then we have what we call these medium-sized expert courses, which are probably a week or two long. And that's what we do, for example, for single port. We have a preceptorship where we have surgeons that want to learn single port surgery. We send them a dome, which is a model deconstruction of all the skill sets. So we asked experts, about 20 experts, what is the skill set that is required to transfer from multi-port to single port? We used a Delphi methodology to identify those. And then we built a dome that has multiple small models. We send that to their institution, they train on that, and then they come to us. And they come to us, they observe us in the operating room, which is a very good learning experience. But then they get to do the cases, the models of the cases that they
Unbelievable.
just saw, right? And then they repeat that again for an entire week. Once they're done with that, we then go back to their institution and proctor them for the first few cases. So what we call this is packaged learning, right? You
Yeah.
do the online platform and learn the basic concepts, and you watch all the presentations and all the didactic lectures. You then practice on certain skill sets that are required to refine your procedural knowledge. Then you come and combine all those skill sets in a simulation while observing an expert. Then we go and proctor you for your first couple of cases. The people that come out of that training platform go from zero to beyond their learning curve within 2 weeks. And then they're allowed to proceed in a very safe manner. And so we've packaged education in different aspects, mainly focused on different lengths of training, but it is really each step of these, we've instilled our models in it, and that allows them to really be able to do the case as if they're doing a case from the very beginning. So you're working out the kinks before they do their very first case.
It's really crazy. I mean, you basically like formalized robotic education, surgical
Exactly.
education. You know,
Yes,
the
that's exactly what we've tried to do.